Welcome to this Step 3 review on Labour and Delivery Management. This video is brought to you by Roadmap to Residency. On the medical licensing exam, labour and delivery questions rarely ask you to recite a definition. Instead, they hand you a labouring patient, a fetal heart tracing, or a stalled cervix, and they ask what you would do next. Our goal today is not to reteach obstetrics. It is to show you how these question stems are built and how to attack them under time pressure. Make sure you are also working through your question bank and a trusted review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn how to read a labour and delivery vignette the way a working physician does, tracking how the cervix is changing over time and what the fetal heart tracing is telling you. Second, we will work through the decision points that these questions love to test, which are when to augment labour with oxytocin, when to simply keep observing, and when to move toward delivery. Third, we will drill the highest yield patterns for caesarean indications and for oxytocin complications, because the same handful of scenarios appear again and again. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read every labour vignette by tracking progress over time. These questions almost always give you 2 cervical examinations separated by a few hours, so your very first move is to compare them. Look at the dilation, the effacement, and how far the fetal head has descended, and ask whether anything has changed. That change, or the absence of change, is the most important clue in the whole stem. Once you have those 2 snapshots, name the stage and phase of labour. Is she in the early latent phase, the active phase, or the second stage where she is pushing? This matters enormously, because a slow latent phase is usually just watched, while a complete lack of progress in active labour with strong contractions can signal a true arrest that the question wants you to act on. Train yourself to pull out the 2 exams and label the phase before you even glance at the answer choices. Strategy 2 is reading the fetal heart tracing, and this is where a lot of test takers panic when they do not need to. The entire trick is timing the deceleration against the contraction. If the heart rate dip mirrors the contraction and recovers as the contraction ends, that is an early deceleration caused by fetal head compression, and it is completely reassuring. If the dip begins after the contraction has already peaked and is slow to come back up, that is a late deceleration. And it is the pattern that should worry you because it signals that the placenta is not delivering enough oxygen. Sharp, abrupt drops that have no consistent relationship to the contractions are variable decelerations, usually from cord compression. Once you have named the pattern, the right action falls out almost automatically. Early decelerations need nothing more than continued observation. Variable and late patterns call for the bedside resuscitation measures first, repositioning the mother, giving oxygen and fluids, and stopping the oxytocin before anyone jumps to an emergency delivery. Strategy 3 is the decision that ties everything together, knowing when to augment labour, when to simply keep waiting, and when to deliver. First, check the contractions before you augment. If labour has stalled but her contractions are weak and infrequent, augmenting with oxytocin to strengthen them is reasonable. But if she is already contracting strongly and the cervix still will not change, adding more oxytocin is the wrong move, and the question is quietly pointing you toward delivery. Second, reserve caesarean delivery for a true indication. The classic ones are arrest of labour despite adequate contractions, a fetal heart tracing that does not recover even after you resuscitate, and a fetus that simply cannot fit or is in a position that prevents vaginal birth. Always match the surgery to a clear reason. Third, and this is the trap, resuscitate before you operate. When a tracing looks frightening, the exam loves to offer an immediate caesarean, but most concerning patterns improve once you reposition the mother, give oxygen and fluids, and stop the oxytocin. Save the operating room for when those measures fail, or the emergency is unmistakable. Let us work through our first practice question, which tests how you read labour progress. A 30-year-old woman at term is in active labour. 4 hours ago, her cervix was 6 centimetres dilated, and she is still 6 centimetres now, 4 hours later. An internal monitor confirms that her contractions are strong and frequent, coming every 2 to 3 minutes. The fetal heart tracing is reassuring with no decelerations. Her membranes are ruptured, and the baby is in a normal position. The question asks for the most appropriate next step. Notice the key facts. She is in active labor, she has made no cervical change over 4 hours, and her contractions are already adequate. Read the 4 options carefully and pick your answer, then we will walk through the reasoning together on the next slide. Let us break this down step by step. Step 1. Spot the pattern. She is in the active phase of the first stage of labor, and she has made no cervical change at all over 4 hours. Yet her internal monitor shows that her contractions are already strong and adequate. That exact combination, no progress despite adequate contractions, is the textbook definition of an arrest of the active phase. Step 2. Apply the rule. When labor has truly arrested in the active phase and the contractions are already adequate, giving more oxytocin will not fix anything because weak forces are not the problem. An arrest of dilation in the setting of adequate contractions is an indication for cesarean delivery. Step 3. Eliminate the wrong answers. Continuing to observe simply delays the inevitable and ignores a real arrest. Starting oxytocin is wrong because her contractions are already strong, so there is nothing to augment. Placing a vacuum is not even possible at 6 centimeters because a vacuum or forceps delivery requires the cervix to be fully dilated. The correct answer is to proceed with cesarean delivery for arrest of labor. Notice how comparing the 2 exams and checking the contraction strength pointed you straight to it. Here is our second practice question, and this one is all about reading the fetal heart tracing and choosing the right first action. A 28-year-old woman at term is in active labor and is receiving an oxytocin infusion. The tracing now shows repeated decelerations that begin after each contraction has already peaked and then return only slowly to baseline. She is lying flat on her back and her cervix is 5 centimeters dilated. The question asks for the most appropriate next step. The key is to recognize the pattern of these decelerations and to remember what we do first when a tracing turns worrying. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, name the pattern. The decelerations begin after each contraction has already peaked and then recover slowly. That specific timing tells you these are late decelerations, the pattern that signals the placenta is not delivering enough oxygen to the fetus. Notice 2 more details: the stem planted on purpose. She is lying flat on her back, which can compress the large vessels and reduce blood flow, and she is on oxytocin, which can be driving contractions that are too strong. Both of those are things you can correct right at the bedside. Now, why does resuscitation come first? For late decelerations, the initial step is intrauterine resuscitation, which means turning her onto her side, stopping the oxytocin, and giving oxygen and intravenous fluids. Very often, these simple measures restore a healthy tracing. Going straight to a cesarean skips the very steps that may solve the problem. Increasing the oxytocin would make the decelerations worse, and waiting a full hour while the fetus is stressed is unsafe. The correct answer is to reposition the mother, stop the oxytocin, and give oxygen and fluids. Let us pull together the cesarean and oxytocin patterns because these are the highest yield decision points in this entire topic. First, know the classic cesarean indications cold, because a small set of them appears again and again. They are arrest of labor despite adequate contractions, a fetal heart tracing that does not recover even after you resuscitate, a fetus that is too large or in a position that prevents vaginal delivery, and a placenta that is covering the cervix. When the vignette clearly matches one of these, cesarean delivery is the answer. When it does not match cleanly, that is your signal to look for a safer intermediate step first. Second, watch oxytocin for contractions that come too often. The signature complication of oxytocin is excessive contraction frequency, which can stress the fetus and produce exactly the late decelerations we discussed. So whenever a stem pairs an oxytocin infusion with a worrying tracing or with contractions stacked too close together, your first move is to turn the oxytocin down or shut it off, not to push more. Very often, simply stopping the drug is the whole answer the question is looking for. Here is our third practice question, and it targets the most common oxytocin complication. A 32-year-old woman at term is in labor and receiving an oxytocin infusion. Over the last 10 minutes, she has had 7 contractions, each lasting more than a minute, with very little rest in between. And the fetal heart tracing now shows late decelerations. Importantly, she is already positioned on her side. The question asks for the most appropriate next step. The detail that should jump out is that the contractions are far too frequent, and they are happening on oxytocin, with a tracing that has now turned worrying. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, spot the cause. 7 contractions in 10 minutes, each lasting more than a minute with almost no rest in between, is far too frequent, and the thing driving it is the oxytocin infusion. When contractions stack up like that, the fetus cannot recover its oxygen supply between them, and that is exactly why the late decelerations have now appeared. So the cause of the problem is the drug itself. Now the key distinction between the options. The stem already tells you she is positioned on her side, so the next logical bedside step is simply to remove the cause by stopping the oxytocin. Increasing the oxytocin would worsen the very problem that is producing the decelerations, so that choice is clearly wrong. Rushing straight to a cesarean skips the simple, effective step that usually resolves the tracing, and the question hints at this by telling you she has already been repositioned. Taking no action leaves a stressed fetus unaddressed and is unsafe. The correct answer is to stop the oxytocin infusion. This is the single most common oxytocin scenario you will see, so make it automatic. Here is a critical exam day pearl that ties this whole topic together, and it is the rule to resuscitate before you operate. Whenever a fetal heart tracing turns worrying, your default first answer should be the bedside resuscitation bundle, not the operating room. That bundle is to reposition the mother onto her side, stop the oxytocin, and give her oxygen and intravenous fluids. A surprising number of concerning tracings recover completely once these simple steps are taken, and the exam consistently rewards choosing them first. Then, and only then, do you decide about surgery. Reach for an immediate cesarean delivery when the resuscitation steps have already failed, when those calmer measures are not even listed among the answer choices, or when the stem is describing a true emergency, such as a prolonged and severe drop in the fetal heart rate or a placenta that is covering the cervix. The rule of thumb is simple. If a safer, calmer first step is sitting right there in the options, it is almost always the better answer than rushing straight to the operating room. Make that order of operations your reflex. That wraps up our review of labour and delivery management for the medical licensing exam. Remember the core moves we covered today. Read every labour vignette by comparing the 2 cervical exams and naming the stage and phase, so you can tell normal patients apart from a true arrest. Read the fetal heart tracing by timing the deceleration against the contraction, and let early, variable, and late patterns each point you to the right action. Know the classic caesarean indications cold, and remember that excessive contractions on oxytocin call for stopping the drug. And above all, resuscitate before you operate, choosing the bedside bundle first whenever the answer list allows it. The best way to lock all of this in is to drill questions in your question bank under time conditions and to read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.